Hello everyone, welcome back to my channel, that is Obstetrics and Gynecology Simplified. Today we will be discussing about amniotic fluid, the normal characteristics and the abnormalities of the amniotic fluid. Okay, what are the normal characteristics? Let's start. See, amniotic fluid, what are the facts? First we will write some important facts about amniotic fluid. First, facts. First, what is the specific gravity of the amniotic fluid? Specific gravity is 1.008 to 1.010. Okay. Osmolality is 250 milliosmol per liter, and it is completely replaced by 3 hours. Okay, so it is completely replaced by 3 hours. So what is the rate of amniotic fluid turnover? It is 500 cc per hour. 500 cc per hour, it is the turnover. So it can be replaced completely by 3 hours. Okay, in 3 hours it will be replaced completely. And what is the volume? See, volume of the amniotic fluid, it is maximum at 32 to 34 weeks of gestational age, and this is a very important question, and it is often asked in the MCQs also and also in the Viva. Okay, so maximum is in 32 to 34 weeks. Okay, that is 1 liter. Then gradually it decreases, and when it becomes post-dated, it becomes decreased. Okay, and then what is the composition? Composition of amniotic fluid, mostly it consists of water. Okay, so water is 99%. Okay, 98 to 99% it is water, and it includes solids. Okay, organic solids like protein, glucose. Okay, protein, glucose, and also lipids, urea, uric acid, creatinine. Okay, these are the constituents of the amniotic fluid. And also inorganic things like sodium, potassium, and chloride. Okay, these are the composition of amniotic fluid, and mostly it is of 98 to 99% it consists of water. Okay, then coming to the origin of the amniotic fluid. So from where it is produced? Origin of amniotic fluid. That is, see, in the early pregnancy, it is because of the ultrafiltrate of the maternal plasma. And then in the beginning of the second trimester, that is less than 20 weeks and more than 20 weeks, it is because of desquamated fetal skin cells. Okay, through the diffusion of the I have told desquamated fetal skin cells. It is from the fetal skin. It is diffusion from the fetal skin, and more than 20 weeks, it is from the fetal urine. Okay. Then so from all these three, see, this one is 16 to 20 weeks, and this is less than, sorry again, so this is less than 16 weeks, 16 to 20 weeks, this one is 16 to 20 weeks, and this is more than 20 weeks. Okay, so what is the major contributor then? The major contributor is the fetal urine. That is the major contributor of the amniotic fluid. Okay, then what is the contribution then? Fetal urine, it is approximately 1000 ml. Okay, and fetal lung is 350 ml. Okay, daily. Okay, then it is kept in balance. See, amniotic fluid is kept in balance by swallowing, fetal swallowing. Okay, it swallows. How much it swallows? It swallows 750 ml per day. Okay, and intramembranous flow across the fetal vessels on placental surface. Okay, so by the intramembranous flow across the fetal vessels on the surface of the placenta, it is absorbed. Okay, so that is absorbed is 400 ml per day. So it is kept in balance. Okay, 1000 ml is secreted by the urine and 350 ml from the lungs, and then it is swallowed 750 ml per day, and the intramembranous absorption, it occurs 400 ml per day. Okay, then what is the color of the amniotic fluid? See, color of the amniotic fluid, normal color. In early pregnancy, it is colorless. In early pregnancy, it is colorless. Okay, and near term, it is pale straw colored or light yellow colored. Okay, and why it is pale straw? Because of presence of lanugo hairs and the epidermal cells from the fetal skin. Okay, because of the lanugo and epidermal cells from fetal skin. Okay, so this is the color, normal color. Okay, so what are the abnormal colors? First, that is green in meconium. Okay, meconium stained liquor. Then golden yellow in Rh negative pregnancy. Then greenish yellow or saffron in post dated pregnancy. Then tobacco juice in case of intrauterine death of the fetus. Okay, then dark maroon in case of abruptio, which is concealed type of abruption. Okay, concealed variety. So these are the abnormal colors of the amniotic fluid. Okay, then what are the functions of amniotic fluid? See, the function of amniotic fluid is function of amniotic fluid. So what are the function? See, nutrition is not the function of amniotic fluid. Okay, that is not the main function. Okay, you must be thinking that nutrition is the main function of the amniotic. No, the nutrition, it comes from the blood. Okay, maternal blood. But the function, it is the main function is to protect the fetus. Protect the fetus by shock absorber. Okay, shock absorber. We are not giving current to the mother, of course. Shock absorber means due to any rapid movement, walking or jogging or anything, the vibrations, the extra vibrations, these are absorbed by the amniotic fluid. That does not reach the fetus. Okay, that is protected. The fetus is protected from the extra vibrations or extra things that are coming from the environment or the surrounding things. Okay, so these are the shock absorber. The amniotic fluid is the shock absorber, and it protects the fetus from any external trauma, external extra vibrations. Okay, and it also helps to maintain the temperature. Maintain temperature. And it gives space for the growth of the fetus, for mobility, growth and mobility of the fetus. And it prevents adhesions of the limbs or any other structures, okay, of the fetus. Okay, so the limbs and the hands, all things can be easily moved. Okay, so that prevents an adhesion. And amniotic fluid, it has no role in nutrition. Okay, I've told you. Then, and also we have to remember that amniotic fluid index. See, what is the normal amniotic fluid index, which is assessed in the ultrasound? Amniotic fluid index. In centimeter, when we see, the normal is 5 to 25 centimeter. Okay. But if we see the single deep pocket, that is STP, that is normal is 2 to 8 centimeter. If less than 2, then it is oligohydramnios, and if more than 8 centimeter, that is polyhydramnios. What is the best parameter to see? STP is the best parameter. Best parameter for amniotic fluid. Amniotic fluid assessment. Okay, so that is the best parameter. Then what about the abnormalities of the of amniotic fluid? See, abnormalities means oligohydramnios or polyhydramnios. We will learn about what is the definition of oligohydramnios. Okay, what are the complications of oligohydramnios? What are the causes of oligo? Okay, we will be learning and how to manage. Okay, so, and what are the complications? Complications is very important. Okay, so that we can know that if the gestational age, at what gestational age, in case of oligohydramnios, how will we manage the patient, okay, in the pregnancy. So the abnormalities of the amniotic fluid, first is oligohydramnios. Okay, oligohydramnios means when the liquor is less than 200 ml at term, or when the STP is single dip pocket, that is, see, let this is the quadrant we are measuring, okay, let this is the abdomen, maternal abdomen, we are seeing the 4 quadrants. So this all quadrants we will just add all the liquor, we will take the single dip pocket where that is free of any umbilical cord or any fetal parts, okay, that we will take and we will add this, okay. So that will be taken as total amniotic fluid index. But when we take a single deepest pocket, okay, that is called as STP, okay, that is the best parameter. Then so if STP is less than 2, then that is also called as oligohydramnios, okay. Then sonographically we can write, if STP is less than 2 centimeter, absence of amniotic fluid, absence of amniotic fluid pocket, okay, that can also be taken. And also A5 less than 5 centimeter, in centimeter it is 5 centimeter, in ml it is 200 ml, in STP it is 2, okay. Then what are the causes of oligohydramnios? Causes of oligohydramnios. First, what are the most common? It is IUGR, intrauterine growth restriction. Then the drugs, what are the drugs responsible? Indomethacin and ACE inhibitors. ACE inhibitors. And then leaking PV, that is also a cause of maternal complication. That is also a cause of oligohydramnios, okay. Then the maternal conditions like hypertension, okay, hypertension, PIH, preeclampsia, post-dated pregnancies, okay. Post-dated pregnancy, abruptio, okay, amnion nodosum, and also renal anomalies. Okay, that is renal agenesis or Puan belly syndrome. And also maternal multicystic dysplastic kidneys, okay. Then what is the most common cause of mild oligohydramnios? The most common cause of mild oligohydramnios is idiopathic, okay. And what is the most common cause of severe oligo? That is renal anomalies, okay. For mild, most common is idiopathic, okay, most common is idiopathic. And for severe, most common is renal agenesis, okay. These are also the questions that are asked in MCQ. Then coming to the complications of oligohydramnios, okay, there can be fetal complications as well as the maternal complications. So the fetal complications include, if the oligohydramnios occurs early in the gestational age, see, we will write about the complications of oligo. That means the liquor is reduced, okay. So there can be fetal complications and maternal complications. if it occurs early in the gestational age, we will divide early gestational age and late gestational age, late term. Okay, so in early it leads to fetal because the liquor is reduced and the fetus, there is no space for growth of the limbs or the other structures of the fetus, so there will be fetal anomalies. Okay, early gestational age, that leads to fetal anomalies because there is no space to grow, and there occurs pulmonary hypoplasia, limb defects, Potter's face. Then, and also it can lead to, in early it can lead to IUGR. Okay, due to uteroplacental insufficiency, there occurs IUGR, and also simultaneously oligohydramnios may occur. Okay, and in late term gestational age, by this time the organogenesis is complete, so there is less chances of fetal anomalies, but when the liquor is reduced, there is more chances of cord compression, and that may lead to fetal distress or meconium aspiration syndrome. Okay, it leads to cord compression and fetal distress, meconium aspiration syndrome. Okay, in late term gestational age. Then, what are the maternal complications? Maternal complications, as there is less liquor, so the labor will be delayed. Okay, so there is prolonged labor. Prolonged labor and intraoperative interference due to malpresentation. Okay, so the sum effect is that there is increased maternal morbidity. Okay, also fetus is affected and also maternal mother is affected, so maternal morbidity is increased. Then what is the treatment? If third trimester there is isolated oligohydramnios, then it is managed conservatively. We can induce the labor and we can wait for normal vaginal delivery. Okay, but oral administration of water also, it increases the amniotic fluid volume, and also we can do amnio infusion. Okay, treatment: isolated oligo and late turn we can conservative management. But also water intake, increase amniotic volume and amnio infusion in case of meconium state. Okay, amnio infusion can be done in case of meconium state. So this is the treatment for oligohydramnios, how to manage. And amnio infusion, it is a technique, okay, to increase the intrauterine amniotic fluid volume. Okay, normal saline 500 ml we can instill through the vagina. Also it is used for dilution of the meconium. Okay, so that we can decrease fetal acidosis and fetal stress or fetal distress. Then in the next video we will be learning about polyhydramnios. Okay, thank you.